the sessions that we're going to deliver. So please, cameras off and your mics on mute as well. And then if you've got any questions as well, please post them on the Q&A and we'll address at the end of all the presentations. Please do not post them in the chat box. If you post them in the chat box, unfortunately, we won't be able to assist you, but post everything on the Q&A. And because of the sake of time as well and progression of our session, please just, when it comes to raising of hands, unfortunately, we will not be able to attend to that as well. So for everything that you have got issues with or concerns or questions, please post in the Q&A so that we can assist you. So enough with the housekeeping. As we begin our session today, I would like to introduce you to Dr. Wahid Bakare with African CDC, so that he can give us an update on the status of COVID-19 in Africa. Thank you.
The panelists, our distinguished participants, ladies and gentlemen, good morning, good afternoon, and good evening, wherever you are. Welcome to session 3 of the ongoing series 6 of the Africa CDC webinar series. Thanks for joining us. I'll be taking you through the situation as of today. Can you see my screen?
Yes, but can you make it full screen, please?
All right. So globally, more than 123 million cases have been confirmed, and more than 2 million deaths across the globe. The map by the left is showing the severity of the cases per country. We can see those darker color showing those ones in more than 1 million cases, and that is how it comes down. The panel by the right, that's the graph there, is showing the new cases reported globally, and we can see the Africa down there at the list at the bottom. Well, this slide is freezing. Okay. So the situation coming to Africa, we can see that more than 4 million cases have been confirmed in Africa, and more than 110,000 deaths have been reported, leaving 2.7% case fatality rate. And the good news is that more than 3.7 million have recovered from COVID-19. The map of Africa by the left is showing the severity on the continent. We can see that only the South Africa has reported more than 500 cases. And that is how it comes down across the continent. Here is the situation by region, by AU region. The new cases reported more than 7,000, and the total cases, as I said, has been more than 4 million. And we can see that Eastern region is the one leading now in the new cases reporting, followed by the Southern region. But coming to the cumulative case fatality rate, Southern region is still leading in the CFR, followed by the Northern region. The number of new cases reported per 1 million population per day by AU member states. 2 countries are reporting more than 100 cases per 1 million population per day. 3 countries are reporting between 50 and 100 cases per 1 million population per day. We have 26 countries reporting between 5 and 50 cases per 1 million population per day. And we have 22 countries reporting less than 5,000, less than 5 cases per 1 million population per day. So there is no data from 2 countries. For case fatality rate, we have 3 countries, 3 member states reporting more than 5% case fatality rate. 18 countries are reporting between 2.2 to 5% case fatality rate. 23 countries are reporting between 1 and 2%, and those are the ones in yellow. And we have 10 countries that are reporting less than 1% case fatality rates, and those are the ones in green. So those of you coming from Sierra Leone, Ghana, you can see them there, Sierra Leone, Liberia, I think. So going to the tests conducted in Africa so far, we've conducted more than 38.9 million tests on the continent, and with 10.6% positivity rate. In terms of tests per case ratio, we are very close to the minimum recommended rate, which is 10, and we are currently at 9.3 tests per case ratio. WHO recommended 10, between 10 and 30 tests per case for COVID-19. So we're around that minimum rate on the continent. The test per case ratio by countries are showing on this map. So we have 7 countries that are testing between 31 and 100 tests per case. They are really doing well, and those ones are colored in brown. We can see 1 country are testing more than 100 tests per case. We have 19 countries testing less than 10, then 27 countries testing between 10 and 30. That is within the recommended rate. So, and those ones are in which color is that? That's around yellow. Then 1 country, there is no data. That is what I have for now. Thanks for listening. Over to you.
Thank you very much, Dr. Bakare, for that situation update on African COVID-19. So as we move along, I would like to introduce Dr. Mary Achinyo. She's with the Ghana Health Service, and she will be taking us through the country perspective on the built environment, focusing on COVID-19. So she'll be taking us through Ghana's experience through this on COVID-19 and how they use the built environment. Thank you. Over to you, Dr. Mary Achinyo.
Okay, so thank you very much. Good morning, colleagues. Greetings from Ghana, wherever you are. It's a beautiful, bright morning here. As mentioned, my name is Mary Achinyo. I work with the Ghana Health Service in the Institutional Care Division as Deputy Director responsible for quality and safety. I'm happy to share Ghana's experience on optimizing built spaces during COVID-19 and the relevant lessons for preparedness for EVD for screening and triaging. Thank you. So the outline for my presentation, I would give a little bit of introduction and the Ghana situation as it stands currently, and then highlight some key IPC lessons learned in the COVID preparedness and response, what implications that has for Ghana as we prepare ourselves for EVD, then also some strategies for optimizing spaces, and then the way forward. On the right, I have a photograph of IPC training of key focal persons in the private and public sector, which was done as part of support from Africa CDC step-down training in collaboration with ICANN. So globally, we now have more than 120 million confirmed cases with over 2 million deaths reported to the World Health Organization. The good news also is that more than 300 million vaccines have been deployed. In Ghana, we recorded our first 2 cases on the 12th of March. And this was interesting because it was a day after WHO had declared the transmission as a pandemic. And since then, we've had over 89,000 cases. But the good news also is that we've had a lot of recoveries, more than 85,000 confirmed cases recovering, with over 700 deaths, giving us a case fatality of less than 1, around 0.7. So Ghana has also joined the first few countries to deploy the COVID vaccines, and we have targeted 2/3 of our 30 million population, which is 20 million. So far, we have had over 400,000 doses administered to prioritized populations, which is a good news. In Ghana, our main strategies for detecting cases have been through routine surveillance, enhanced contact tracing, where we had most of our cases. And so most of our cases were asymptomatic from the beginning. But we've also had compulsory testing of international travelers at the Kotoka International Airport. You can see also on the right, we have a graph showing distribution of COVID cases in Ghana by the weeks that samples were taken. We have had 2 waves so far. The first peak was in the last week of June. And then also in the last week of January, we had a second peak following Christmas and also election activities. The good news, as you can see, is that we have also successfully tried to crush the second wave. And we hope to strengthen our interventions to ensure that we do not have a third wave, as some countries are experiencing. So from these 2 waves of IPC implementation in the COVID response, we have learned some key lessons that we think it's also very useful to strengthen IPC in EVD preparedness. So in the case of Ghana, the IPC interventions officially had been part of case management and not a pillar on its own. But we feel that governance of IPC, in order to promote the appropriate scope of implementation going forward, it is more important, or it has more merit to have IPC as a thematic area or a pillar on its own as part of the COVID response. So this is a key lesson. Governance is everything. So this is a key lesson we have learned, and we hope we will use that for the EVD preparedness as well. As part of that, we have also realized that much of our concentration in the beginning of the response was limited to healthcare facilities because of, again, being part of case management. But the scope must also really extend to households and communities, especially in EVD. We have also seen that local policies are great to start with, to be augmented by international guidance. And if we quickly adapt or adopt tools and standardize them early in the response, it's very useful, because this gives a lot of leadership and assurance to healthcare facilities at all levels. This was one of the areas where we lagged behind. So that has also been a key lesson. In terms of information and research, we have seen that depending on how research and information is shared, we can either build trust between healthcare systems and communities in order for them to comply, or otherwise. And in risk communication, theory versus reality, what has really worked in Ghana's case has been the reality. So we started with a theory, but people did still not believe in the existence of the virus because they were not seeing COVID-19 patients. But when we changed our risk communication strategies and showed some of the patients who were in our hospitals, and also used key persons to create more information and advocacy, we had people complying to IPC protocols. In terms of logistics, what has been helpful is local accreditation and production of PPEs and hand hygiene materials. This is even more very important as we go to EVD preparedness, because at this point, countries are economically really, really hard pressed. We have also realized that WASH has been critical in adhering to IPC protocols, especially in healthcare facilities. In most of our treatment centers, the water domain is where there were more attention and focus. But in terms of sanitation, hygiene, and then also leadership, we found more gaps there. For IPC education, it's been the convention that because we adopted a risk-based approach, we perceived clinical staff as being more at risk, and therefore they had more attention for training and provision of PPEs. But when we conducted a study on risk assessment of frontline workers, we realized that actually the non-clinical staff were more at risk of getting the infection and also serving as agents for transmission. And so there was a need for us to also pay attention to them as well. These non-clinical staff could be constrained in their ability to be trained on IPC based on their educational status. So the key lesson here was to develop a separate model for them, which is very, very simple to convey the message, and where appropriate to be translated into local languages for the training to be done, particularly for mortuary workers. With the introduction of several technologies for training, we also explored remote learning, but we realized that where we added supportive supervision, it became more useful to frontline workers. Anxiety management had been very, very important for frontline workers, and also surveillance of the health of the frontline workers. So some of our healthcare workers who got infected, and unfortunately some lost their lives, disappeared from their station within 24 hours, where there were no active surveillance on healthcare workers. These were not picked up until they were found later to be infected, and some lost their lives. So that had been very important. For IPC economics and politics, supply chain, we have seen a lot of pull and push factors. So you have logistics that before the COVID response were selling for maybe $10, suddenly jumped to $100 or $200. And governments can mitigate these forces through appropriate private-public partnerships to increase access of these logistics to not just the healthcare workers, but also the general population. So as a country, as we discuss or start the EVD discussion, what is very important for us, the implications of these lessons we have learned, is the fact that just as for COVID, for EVD as well, we need to build capacity for both clinical and non-clinical staff. And we also need to explore affordable PPE supplies in the wake of the economic status. Governments had to invest heavily in the COVID response, and already seeing some recession in that regard. So we need to really explore more effective, efficient, and affordable means of providing these PPEs. So healthcare workers' safety is really, really critical, especially at this point where people or healthcare workers are really fatigued physically, emotionally, and psychologically. This is something we would really have to pay more attention to. And certainly WASH in treatment centers. Also risk communication for IPC adherence. We need to focus on the realities than the theories. That is the key message for risk communication for IPC adherence. Research within local context. So yes, as a country, we have tried to align our policies with the international scientific community as much as possible, but we think that local context is also a very good starting point whilst we wait for the evidence to be able to align internationally. Then we also need to leverage on very simple administrative controls in low resource settings such as Ghana. The key lesson is that administrative controls don't need to be very, very complex. Once the principles are adhered to and making sure that there's strict IPC compliance in place, it also provides a very safe way of screening and triaging patients or suspected patients. Yeah. So Ghana as a country, we really are yet to start active discussions on EVD due to the vaccination exercises. However, we have maintained in place all the relevant measures put in place during the COVID response. For instance, all our 40 points of entry still remain closed, except the international airport, which remains open to human traffic. We have also issued alerts to all healthcare facilities to strengthen the existing COVID responses strategies for EVD preparedness as well. Now, Ghana's experience in screening or pre-triaging in COVID-19, we have identified 5 major strategies in our healthcare facilities. For healthcare facilities that have a lot of space outside their facilities, what we have used is canopies outside the hospital. However, some of our hospitals are also situated very close to streets. The challenge is that most of our healthcare facilities have been repurposed. Some have actually grown from health center to a polyclinic, then to a district hospital, and to a regional hospital. So in our designated treatment centers, we do not have screening ongoing for COVID patients because everyone coming into these treatment centers are already confirmed. But we have screening for healthcare workers and visitors. However, apart from these designated treatment centers, currently our strategy is that every other healthcare facility is also a treatment center. Hospitals should be able to detect their cases, test them, and then institute the appropriate management strategies. And so you realize that for hospitals who are located perhaps very close to the streets and are not able to mount these canopies outside the hospital, they locate it very close to the entrance of the hospital within the wall. And so the wall of the hospital becomes the outside border. So immediately you enter this facility, you will see the canopy mounted. In other settings where there are smaller healthcare facilities, the screening is done just at the entrance of the healthcare facility. In other hospitals, there have been erection of new non-canopy structures, so simple wood roofing, some bricks, and then it's also situated well away from the main infrastructure where the service is being delivered. The interesting thing is also that for some of our healthcare facilities, the screening area is just a table and a chair, but with all IPC principles in place. So the principles are that there should be a temperature check, and this is for, let's say, corporate settings. They really don't use any tools. But when you come to healthcare settings, beyond the temperature check, we also have a tool which is mainly based on the case definition. And then we ensure that there's basic equipment provided, thermometer to check temperature. We also ensure that there are appropriate IPC logistics like hand sanitizers and PPEs. So we have seen that from our experience, we have done both the structured and the non-structured, such as just a table and a chair for screening. but we have ensured that there's appropriate holding and general areas as part of this screening. And then we also make sure that those who meet the case definition or are suspected to have COVID-19 are linked to appropriate care, testing, and management. So the key lesson here is that we don't have to get a very complex screening. It's the principles that should be upheld to make sure that suspected cases do not slip into the healthcare facility to increase hospital-acquired infections and also keep increasing transmission of COVID-19. Now, with that experience going forward into the EVD discussion, on the left is a model screening and triage setting being advocated by the World Health Organization. And this is an ideal situation where we have a staff entry, staff zone, and then we have a separate zone for patients, one entry, and then depending on the outcome of the screening, they either take an exit to transfer with a strict IPC to the ETC, or they exit where they do not have Ebola, or where they are not suspected, or where they don't meet the case definition for Ebola. So currently for Ghana, we do not have a tool in place for the EVD response. However, we started these discussions before they slowed down due to vaccination, the COVID vaccination rollout. We anticipate that we could have a combined tool, and we need to make this as simple as possible through an algorithm that would enable differentiation between the two diseases at some point based on the case definitions. And also to uphold the principles, making sure there's an equipment to take temperature, appropriate IPC practices, and also making sure that these are located outside the facility with good holding areas, also linking them to testing and care where indicated. So moving forward, with the lesson we have learned with governance, we think that what we have to promote is the Ipc Ring Approach, so that we are looking at beyond preparedness, we're also looking at response in healthcare facilities, households, communities, including churches, schools, etc. So within the healthcare facilities, assessing the situation, giving the necessary support, providing the necessary logistics, and following up to assess whether IPC measures are upheld, but also the households of the cases, and then also the communities within which these cases are located. So what we will be doing will be to heighten stakeholder engagement after the initial vaccination activities, to promote the Ipc Ring Approach, and also advocate for IPC to be a standalone thematic area. As we see, the case management is within the healthcare facility ring. That is the first ring, but we also need to look at the households and the community rings as well. Ensuring WASH in healthcare facilities, households, and communities will be very, very critical. And IPC capacity building for healthcare workers is very, very important, with a focus on not just clinical, but both clinical and non-clinical staff. And certainly for efficiency and for all the relevant lessons we have learned, we will be leveraging on the gains that we have made from the COVID response as shared earlier. I want to end by acknowledging the National IPC Response Team, the Ghana Health Service and the Ministry of Health, our partners, Africa CDC, UNICEF, WHO, ICANN, and all the other development partners we have worked with in the IPC space. And then also to thank you all so very much for listening. Thank you.
Thank you very much, Dr. Mary Ashinyo, for that very informative session. And I'm sure most of the things that she discussed are not only unique to Ghana, but we'd find that they are also in our environments, and same with the issues, and also highlighting the importance of improvision and using what we have to adhere to principles and standards around infection control. Just a reminder as well for all panelists, if you've got questions for the sessions that we've had, please put them in the Q&A and not in the chat box so that we can attend to them at the end of all the presentations. Thank you so much once again, Mary Achinyo. Moving right along, I'd like to introduce you to Ms. Niniola Williams, who is the Managing Director of DRASA, and today she'll be presenting on behalf of ICANN, and she'll be also looking at the built environment and WASH, looking at how we can optimize our spaces, all the spaces that we allocate, how we can optimize them during COVID-19, and of course now during EVD that is ongoing. So she'll be looking at triage, and she'll be also looking at screening. Thank you. Over to you.
Thank you, and good afternoon, good morning to everyone. Let me just make my screen full screen. Okay, so as mentioned, I'll be speaking about setting up our environments for IPC. I think for screening and triage, I think this is a very important topic today, knowing that COVID-19, as we heard in the beginning of this session, is still very much with us, and Ebola is as well. So ensuring that whether we are frontline health workers, whether we are management, whether we work for the ministry, it's very important for all of us to know how to screen and triage appropriately. So the outline for this presentation is as follows. I will start by giving an overview of triage, what it means, how it happens, what we do, and then I will speak about the IPC specific measures for triage. So I want to start by asking a question. Can we just have people put their answers in the chat box? What is triage? Is it a process or is it a place? If we want to do triage in our health facilities, are we talking about a process or a place? Let's just have some answers in the chat box, please. I see some saying process, some saying place. Okay. Process seems to be winning, but we have a few people who say both. Okay, very good. Great. Great, thank you for the answers. Please, let's keep them coming. The answer is it's actually a bit of both, but it's more of a process than a place. And I want to emphasize that we don't want people to get stuck on the fact that they may not have a suitable place to conduct this process. As Dr. Mary just shared with us, there's formal and informal ways of doing this. There are ways we can manage and improvise and find a suitable place that we may not have today to be able to do this process. But when we say triage, what we're talking about is it's a process of looking at individuals, patients as they arrive, and making decisions and putting them into categories. So the question is, if we look at them, what categories are we putting them into? There are different types of categories, but the ones I'll just share here, for example, are 3. So we have those who are going to come and need immediate care. They are given priority and they are not allowed to sit around and wait for any reason. Those include, now this category 1 here, which is red, includes potentially suspected cases of communicable diseases. Category 2 is those that need urgent treatments. And then category 3 are those that are not urgent at all. So this is an example of a process of triage, looking at and assessing patients as they arrive and putting them into categories. So that's really the process that we're talking about. So I'm now going to specify how we do this for communicable diseases such as COVID-19 and Ebola virus disease. So the first thing is, why should we do this? Why should we bother ourselves with this process of separating our patients as they arrive at our health facilities? The answer is what Dr. Mary shared with us earlier. We know that it's very easy for a patient to enter a health facility and for that health facility to become sort of a reservoir or an amplifier of a potential infection like COVID-19 or EVD, where the community becomes at risk. Of course, the health workers, visitors, patients, everyone involved now becomes at risk of infection when unknowingly we admit or allow patients to enter without the screening and triage process. So we need to do this in order to protect public health. We need to do this in order to identify potentially sick patients. It's really about recognizing and isolating suspected cases of, for example, Ebola and COVID-19. And I know that many of us on this call have been attending the Africa CDC weekly webinar, so we should be familiar with what is on the right side of the screen, which is the chain of infection. And this chain of infection tells us how infectious diseases spread. The idea of triage is to break this chain of infection, to stop the spread, to limit transmission, and of course, to protect health workers, patients, and visitors. It also supports our surveillance structures within our countries. So if we're able to identify a suspected Ebola case or a suspected COVID-19 case, we can also alert the public authorities, public health authorities, so that it can become part of our national surveillance. And we know, of course, that the earlier we find and recognize these cases, the more we can control these infections at their source. So these are all the reasons why we should conduct triage at our facilities. So we know what it is, we know why we should do it. The next question is, how do we actually do it? How do we triage? What is involved? And this is a summary of what it takes. We start with screening. Then if we screen a patient and we think that they may have whatever we're screening for, we then isolate that person. From the point of isolation, the next thing is to notify the right authorities. Now, this is assuming that the triage process is occurring in a place that is not a designated treatment center for whichever disease. So this is not the process we would follow if we're already working in an Ebola treatment unit, because we're assuming that the patients there are already confirmed, right? We're already treating them for Ebola. This is the process we follow at the primary healthcare level, secondary healthcare, and tertiary healthcare levels, in our general hospitals, in our primary healthcare centers, in places where we are not aware that we are treating infectious diseases, but we know that those patients may come. So I'll start with going through the process of screening. And just to note, sometimes we say screening, sometimes we say triage, but it's important to remember that screening is a component of the overall triage process. Triage is really what we're talking about today. So how do we screen? Step one in triage is to screen. The first thing is to look for signs and symptoms. But then how do we know what we're looking for? How do we know how to sort and divide our patients into the different categories for triage? We need to have a screening tool. And I'm very happy that Dr. Mary was able to describe what they've done in Ghana. We must have a standard screening tool that everybody is using at the screening point in our health facilities. And how do we develop that? We should look at the case definitions for whichever infectious disease we are screening for. And if it's a combined tool, then we need to have signs and symptoms and case definitions for both of the diseases that we're screening for in combination. So in this case, if we're screening for COVID-19, the screening tool would be specific to COVID-19. If we're screening for Ebola and COVID-19, then we may have a longer questionnaire or screening tool that we use. But the idea is that it must be standard, it must be something that is printed and available so that everybody that's doing the screening is following the exact same process. So this is an example of an Ebola screening tool. You know, things like in the last 21 days, have you traveled? Have you been exposed to someone who has been sick? Things like that. We have this type of screening tool, which is for COVID-19. Have you had close contact with anyone that has been confirmed or suspected? Have you been to a healthcare facility where COVID-19 patients have been treated? Do you have fever, coughing, difficulty breathing, sore throat, and so on? So there are different types of screening tools, but they must be based on the situation in our countries and our regions at the time, as well as the specific case definitions that are available. So for example, if we know we are in the phase of the pandemic where we have widespread community transmission, that should be reflected in the type of tool that we're using. Now, something very important to note with screening tools, they're very handy and they're good as the first step of triage, but we should not use them and have 100% confidence in them. And the reason is that someone can report that, oh, you know, I've not been exposed to anyone with Ebola. I've not been exposed to anyone with COVID-19. So that negative exposure history does not mean that person has not been exposed. They may not be aware that they've been exposed, number one, or they may not be telling you the truth. And the reason is because we know there's a lot of stigma, there's a lot of fear. Some people don't want you to carry them away into an isolation area if they say that, yes, I've been around someone that has these conditions. And there's a lot of distrust. We know there's, you know, a lot of different issues. So just because someone says they've not been exposed doesn't mean that during the screening process, we don't ask other questions or investigate further. Then part of screening, apart from using the screening tool, is also the temperature check. Now we know that the process of doing this is to hold the thermometer. The no-touch infrared thermometer should be held 3 to 5 centimeters from the person's temporal area. And if it's less than 35 degrees Celsius that the reading shows, we should do it again. If it's over 38 degrees Celsius, we should repeat the reading and be very sure that that is indeed indicating high temperature or fever. And that would then be an alert case. So this is an example, a diagram showing exactly how we do this, the screening process, how we do the temperature check during the screening process. So how do we set up a screening area? And we spoke a bit about this, and I saw a question in the chat box about what does a canopy look like? How do you do it? Many of us have health facilities that don't have this built. Many of our health facilities are either converted buildings or perhaps buildings that were built without the intention to provide an area for screening. So we may have to improvise, we may have to find a way to do it on our own. And the truth is that the screening, first and foremost, must take place at the entrance to the health facility. As much as possible during a pandemic, during an outbreak, during a public health event, we should have only one entrance to our health facility so that we can ensure everyone that enters is screened. And if not, then we should have the screening area as close as possible to all the side entrances. But ideally, it should take place, the screening area should be at the main entrance to the health facility, and screening should be done consistently, at all times, for all shifts, for all people. We shouldn't say, oh, because this person is just an administrator, they can enter. Or because this person is just a cleaner, they're not clinical, they can enter without screening. Or because this is the managing director of the facility, we don't have to screen the person. Everybody should be screened, and it should be done 24 hours a day, 7 days a week. The screening area should have unidirectional flow, meaning that patients just walk in one direction into the facility. That way, we don't have to be confused about, oh, did this person just come 5 minutes ago? Has this person already been screened? If people are walking back and forth, it makes it a bit difficult to screen very well and to keep track of it. We must have trained staff at our screening areas, and this is very important. I know we have some hospital managers on the meeting with us today. It's not enough to just set up an area and put someone there. The person who is there must be trained, and they must be supported with the materials and supplies that they need. And we'll speak about that shortly. And if we don't have an existing area to screen, we can use a canopy or any outdoor area. Really, all we need is what is shown here: a table with the supplies and materials, and a process where patients who want to enter the facility can queue up in an orderly and spaced out fashion. So we need a well-defined area, meaning that it shouldn't be just done in the car park or just in front of the hospital on the street. It should be an area that is defined and marked off, and it should have good ventilation. Of course, with things like COVID-19, we don't want to have it in a closed room, for example. We must be able to keep patients and the health worker as well who's stationed there at 1 meter or greater distance from each other. We don't want a crowded area. So if we have a very small, maybe front compound of our health facility, that may not be an appropriate place to conduct the screening. We must also have clear signage. It's important to educate our patients. They may not understand why they're being stopped. They're there to seek medical care. They may not understand why they're being stopped at the front, to be asked different questions. So we must have signage like the one here on the screen that says this is a mandatory temperature screening or triage station, so that people can be aware. At the screening area, the things we need are the standard screening tool, which I've described, job aids and protocols. I'll show an example of that next. And those are to help the health worker there ensure that they can remember what to do. Because when you're faced with a potential emergency, it's oftentimes hard for the person to recall what the protocols are. So having it printed or displayed either on the wall or on the table at the screening area is a very good way to support that health worker to do the job of triage. Then any documentation we may need, a registration book, important contacts. So if we screen and we now need to call for support because we say, okay, this person is coughing, this person has fever, this person has a travel history, this person has been exposed to someone with Ebola, who do you then contact? What is the next step? Who do you notify? What is the phone number you call? We need to ensure that those contacts are available at the screening area. And then we should also have educational posters for our patients to remember about things like hand washing and cough etiquette and other IPC measures. This is an example of a job aid. So for example, triaging for COVID-19, this is a job aid that would help the health worker know what to do. Once I identify a sign and symptom of COVID-19, if the answer is yes, this patient has signs and symptoms of COVID-19, I would remember that the next thing I need to do is place a medical mask on the patient. And then after that, I separate the person. And if the person does not have signs and symptoms of COVID-19, I can allow them to continue to access care within the facility. So this is an example of a document that can be printed and left on the table so that the health worker during the screening can be aware of what to do and can remember the process. In addition, we need hand hygiene supplies, whether we have a sink and a tap or whether we have a Veronica bucket that gets filled. we need supplies for hand hygiene. We could even keep it as simple as just alcohol-based hand rub, sanitizers. We need the contactless infrared thermometer. We need masks and other PPE, which we'll speak about shortly. And we need waste bins and the ability to clean and disinfect in case of a suspected case of COVID-19, Ebola, or any other communicable disease. And again, I want to just remind us that the process of screening, the process of doing this triage, which screening is the first step, is more important than the place. We know that many of our health facilities don't have suitable places for screening. They were not built to have a screening area in the front or at the main entrance, but we can improvise. So you can see some pictures here of what others have done to improvise screening in their own health facilities. Here are two more pictures. And then to answer the question that was raised in the Q&A box, you can see here on the right how they used a canopy, so that though this would have been otherwise done in the open air, they have a canopy to protect them from the sun, the rain, and the elements. And yet they've not closed the canopy entirely, so that there's still good ventilation and airflow. So these are examples of where screening can occur. So once we've identified a suspected patient, that patient must perform hand hygiene, respiratory hygiene, wear a medical mask. If they're wearing a cloth mask, they should be given a surgical or medical mask. And then we must ensure that that person is kept away, 1 distance or more from other patients. So that is the screening process, the first step of triage. The second step is isolating. So once we have a suspected person, we need to put them in an isolation area. So how do we set up an isolation area? Please note, they cannot be isolated within the screening area because the screening area will have people moving through it. The isolation area needs to be a little bit separate from the screening area. And it could be something as a simple room that has clear signage, or even just a side of another area that has been designated. And I'll show some pictures and examples of that. One of the most important things about the isolation or holding area is that we must have signage. We don't want it to be a place that other people can just walk into because they don't realize what's happening there. There needs to be clear signage like what you see on the screen, informing people to stop and pause and realize that the person inside this room is under droplet precautions or contact precautions. I won't go into what those things mean because I know that we have had previous webinars talking about these IPC terms, and I encourage all of us to go back and check the recordings. But we need to have the signage to inform people that this is not just a normal room, but that there's a suspected case of someone with a droplet infection or a contact infection inside. That person, while they are in that isolation area or holding area, they must have access to a toilet or a latrine, because what would be not ideal and not compliant is if we had someone isolated who then needed to use a bathroom facility and had to come into the main hospital to do so. We've seen this happen in facilities before where they did not make provision for toilets within the holding area. And then when the patient who is being suspected of COVID-19 or Ebola or anything else, when that person now needs to use the toilets, they have to come out of the isolation area, potentially infecting those around and contaminating the general toilet. And we should ensure that it has its own exit so that when it's time to transfer the person out of that facility to a dedicated treatment facility, they can easily be moved. Now, again, if we don't have decent or predefined isolation areas in our facilities, there's no problem. This is an example here of a type of space that was used. So you can see the chair in the back is the isolation area. It has a waste bin. Though the waste bin should have a red nylon for infectious waste, this is an example of a very simple way of doing a holding area. The chairs in the front create a barrier so that people cannot just walk towards the person sitting at the chair behind. And it says, do not enter, designated personnel only, which means that everyone will be aware that the person sitting there, there's something happening. There's also a register on the chair that says, if you're going to enter this place and attend to this patient, you have to write your name and your details so that we can also track contacts of this person. So we can ensure that if we don't have a single room available, if we don't have an area, we can even just use something as simple as this. The place should have good ventilation. It should have a way of preventing people from entering. And if we have more than one person inside this isolation area, they must be 1 meter or 3 feet apart from each other. These are other examples of how we can do holding areas where we just designate seats. It doesn't have to be a bed. It doesn't have to be a complicated place. The idea is that this is a temporary place we're going to keep the person until they are now evacuated or moved to a place where they can get the proper care that they need, as well as get tests done to know whether or not they have the infectious disease we are suspecting. So we need to think about the ventilation and how we can ensure we move the person without infecting others. So just because of time, I'm going to quickly go forward. Other things that need to be in the isolation or holding area: hand hygiene stations, of course. If not, we need to have at the very least hand sanitizers available. And then either a bed with a plastic mattress cover or a chair so the patient can be comfortable. We must also ensure that before we take someone from the screening area to the isolation area, we counsel them. We've had issues in the past at the health facility level where patients have felt stigmatized or discriminated against because it was not communicated properly to them why they were being moved to a place to sit alone or why they were being isolated. So counseling our patients is very important. And then if we need to move the patient from the screening area to the holding area, the isolation area, we need to think through where we're moving them. If the screening and isolation areas are not close to each other, we must have a predetermined route that we're going to walk through where we know that the road will be cleared and people will not be around as we move that person. Of course, the health workers involved in transporting these patients must wear their PPE, perform hand hygiene. And then when we get to that, before we get to that isolation area, we must notify the people who are there that we are coming so they can prepare for the patient's arrival from the screening area. Again, we want to limit the number of health workers and people who have contact with the holding area. We need to have this record book or register book for everybody that's going to enter that screening area. And then if we have staff attending to the person at the isolation area, those staff must not be engaging with other patients. So if I'm a nurse assigned to attend to the person in the isolation area, I must remain there. I cannot go back to my general ward to treat people there because I could potentially track the infection from the isolation area to the general ward. Anything that is brought into the isolation area must stay in there until it is disinfected or disposed of appropriately. So medical records, mops, anything that we take in must remain in there and must not be used elsewhere in the health facility. The final step for triage is notifying the authorities. So we have screened, we've found that we have a person that's suspected to have, let's say, Ebola. We've isolated the person, we've moved them from the screening area to the holding area. Once that happens, we need to notify the right authorities. And please note, these are both internal and external authorities. So we must start by notifying those internally within the health facility, and then we must notify those externally, such as the public health officials, maybe at the states or provincial level, as well as the national system of surveillance. So this is a summary of what we're talking about. If the patient has symptoms, we move them and notify. If they don't have symptoms, we allow them to continue with their visit to get their care, but we must remain using our standard precautions with all patients, regardless of whether we're suspecting them or not. Now, it's always appropriate for us to get a second opinion. There are times when at the screening point, we're unsure. We are not sure whether this person should be moved from screening to isolation. In that case, we must have a system at our health facilities where we can call on our colleagues to assist us and to be sure that this person should indeed continue receiving care or instead should be moved to isolation. So who should be the people conducting this process? Who is screening? Who are doing all these things? The answer is that ideally it should be a nurse, but if not, a nursing aide can also be. But the most important thing that we must note about this is whoever is in charge of this process must be trained. It's very important that we step down what we're sharing today and what we've been sharing over the last few weeks within our health facility so that the people doing this important job are equipped and able to do it to the best of their abilities. Security guards should not be screeners. They should not be the ones doing this because they don't have the clinical training to be able to know what to do in case of an emergency. Again, a clinician should be available to support the person screening whenever complicated cases arrive. And the person screening should have a high level of suspicion. We should ensure that we're doing everything we can to catch these cases at the screening point before they enter the health facility and become healthcare acquired infections that other people can then be transmitted to. So what are the IPC measures for triage? Very quickly, standard precautions for all patients. So everybody coming to the screening point, for example, we must be doing our standard precautions. And then at the point at which we suspect, okay, this patient may have COVID-19 or this patient may have Ebola, we now add on top of the standard precautions, we add our transmission-based precautions. I won't go into the detail of that again because I know we've spoken about this in previous weeks of this webinar series, but it's important to know that those things should be added once we have an idea of what we may be dealing with, what we may suspect the person has. On top of that, we should always be using our administrative controls and our environmental and engineering controls, which are more important than PPE, as you can see on this slide. Administrative and engineering are more important than PPE. Now, what are administrative controls? Training. So for example, this session we're having right now, this webinar is an example of an administrative control, and stepping this down to others in our health facilities is also part of it. Also monitoring compliance, what we're speaking about here. The process of screening, the process of isolating, the process of notifying, it can only work if we are monitoring and evaluating what we're doing. So we need to have a process by which we can check for errors and gaps and find ways to improve upon what we're doing in terms of triage at our health facilities. And then we also need to establish a surveillance process amongst health workers ourselves. Oftentimes, like I said before, we don't screen ourselves, we only screen the patients. We forget that we can also be carriers of infections. We can also be those that seed infections into the health facility. And so we must ensure that we're also conducting screening amongst health workers. And then ensuring adequate patient to staff ratio is also part of administrative controls. When we talk about engineering controls, again, adequate ventilation, both in the screening area and within the facility as a whole, then we need to ensure that social distancing, separating by 1 meter or more, is important as we're doing this triage process. As we go through the process of screening and isolating patients, there must be distance involved, both between patients and between the health worker and the patient. I'm sure many of us may be familiar with the fact that we can actually check temperatures and do temperature screening from behind the person. The person doesn't have to be face-to-face with us for us to be able to do those things. Those are different ways that we can use environmental and engineering controls to protect ourselves in the triage process. Adequate wash infrastructure is very important. We know we cannot successfully practice IPC without the water, sanitation, and hygiene requirements we need, from sanitation systems and waste disposal systems, human waste disposal systems, to the access to clean water and hand hygiene facilities. These are all parts of practicing IPC in the process of conducting triage. We also need to have access to cleaning equipment. It's very important. If we have, for example, interaction with a suspected case, that screening area now needs to be disinfected. So where do we get the cleaning and disinfection supplies from? Those are important things to have available, as well as other IPC supplies like soap and sanitizer, PPE, and so on. And then safe waste management is also a big factor, environmental control. When we talk about waste management, we need to understand that at any point having a suspected case, the waste generated from interacting with that patient needs to be considered infectious waste, not general or domestic waste. Now, what do patients do? In the triage process, patients that are suspected to have, for example, COVID-19, must practice their respiratory etiquette, covering their nose and mouth with a tissue or sneezing and coughing into their inner elbow. And they must also practice hand hygiene. And as mentioned earlier, they must be given a medical mask. So these are some of the IPC measures we need to train and educate our patients on at the point at which they are suspected to have an infectious disease. The same thing goes for Ebola and others. So for health workers, if we're suspecting COVID-19 and we need to put the person into an isolation room, and while they are in the isolation room awaiting evacuation to another facility, we may need to provide them with some care. And in the process of caring for a suspected case of COVID-19, we need to be aware that it's a droplet infection. So that means that we need to take droplet precautions. But if we're doing any aerosol generating procedures, we need to use airborne precautions. And of course, we need to do our standard precautions such as hand hygiene, cleaning and disinfection, not touching our faces, and also using risk assessment to choose which items of PPE we will use. Now, when it comes to PPE, we need to designate where we're going to wear it and remove it before we enter the holding or isolation area. That's very important. We cannot, attend to a suspected COVID-19, Ebola, or any other case without the process of donning and doffing appropriate PPE. And again, we've spoken about this at length in previous webinars, so I won't go into the process today. But the basics of PPE for triage are that we need to conduct a risk assessment. What am I going to do? If all I'm doing is screening a patient at a 1 meter distance, I don't need to wear a hazmat suit or a coverall. I don't need to wear a gown. I don't even need to wear gloves because I'm not going to touch the patient. I'm going to screen them by asking questions 1 meter away, and then I'm going to approach them from behind to take their temperature. So there's no contact between the patient and I. Therefore, my PPE is very minimal and just requires a mask, a surgical mask. That's an example. So we need to think about what we're going to do, and that will inform what we wear. And then we need to follow the appropriate methods for removal and disposal of PPE during the triage process, and also be mindful of our 5 moments of hand hygiene. So again, if we're screening for COVID-19 and all we're doing is screening and educating patients, all we need is a surgical mask. We don't need to wear all the PPE because it's not required for this particular activity during triage. But if we are going to assess a patient, so a patient has been screened and has been moved into an isolation room suspected of COVID-19, we then need to wear the appropriate PPE in order to attend to that patient, which includes face shield or goggles with a face mask, a surgical mask to protect our mucous membranes, as well as gloves and a gown. So in summary, each health facility needs to develop a system for triage. We need to ensure that no matter what is happening at the community level, at the national or regional level, with either outbreaks, epidemics, or pandemics, we have a system in place that can be activated at any time. A system in place that is consistent and is active for all visitors to a health facility, whether they are staff, patients, or patient relatives. And that system must go through the process of first screening and then isolating and then notifying. And of course, we know that if we have suspected cases, we need to put them immediately into an isolation area to help us break the chain of transmission and then notify the appropriate authorities. And again, when it comes to protecting ourselves as health workers, we look always at our standard precautions. Standard precautions cannot be more emphasized as the most important parts of IPC, ensuring that we are practicing them for all patient encounters, no matter what. And then also using distance and appropriate PPE to provide additional protection for us is important. Thank you very much.
Thank you very much to Ms. Williams for that very comprehensive and informative presentation that was looking at our spaces in terms of infection control when we're looking at COVID-19 as well as EVD, and touching a lot on screening and triage and the importance thereof. At this juncture, I would like to thank all the presenters today for a very informative session. Thank you to Dr. Bakare, who was our first speaker. I'd also like to thank Dr. Mary Ashinyo, and also thank you, Ms. Williams. I'd like to hand over to Dr. Wande from Africa CDC to handle all the questions and answers that you have inputted during the sessions. Thank you.
Hello, no, it will be Professor Val Robertson who will be taking the question and answer.
Oh, okay, thank you. So
Yes.
over to Professor Val Robertson to handle the Q&A. Thank you very much.
Thank you very much, No, and thank you to our speakers for excellent presentations. It's always useful to really go through the detail of what we need to know in terms of screening of our potential COVID-19 patients. And that I felt was an excellent presentation. So, and also to hear a country example, because I think all of us have a lot of challenges. So to hear from Dr. Ashinyo from Ghana about how they'd approach this in Ghana. And I was interested to hear that initially they linked in IPC with the case management response, but then learned that it should be a separate pillar. And I think this is really important. So let's get to the questions. Please, can we ask you again to put any questions that you have in the question and answers box and not in the chat box. So perhaps I could begin with our first speaker and the first question, which was looking at the discrepancy of case fatality rates in the different regions of Africa. So a higher CFR in Northern and Southern Africa. The question is, why? And I wonder, Dr. Bakari, if you have any response to that question. Dr. Bakari, are you there? I think Dr. Bakari may have left the panel. Could we have any response from any of the other panelists? Prof. Ogunzola, are you there? I think we have lost some of our panelists. So can I have a response from anyone on the panel? Could we have a response from anyone on the panel? Dr. Wahid?
Yeah, I think the internet has been challenging. Can you come again with the question?
So the question was about the discrepancy, the differences in the case fatality rate in the different parts of Africa. So we have much higher CFR in North and Southern Africa, but much lower in West Africa and East Africa. So the question was why? Does anyone, can anyone explain the difference and why that difference arises?
I think one thing we need to check first is the rate of testing in across those regions. But the other thing that we need to check is the numbers of people living with underlying conditions, the number of overage people, you know, who might be prone to serious or severe infections from COVID. So maybe the data will explain this better, but based on what we have at the moment, I think it is the country that will say, because, you know, when you have data, when you receive data, data will not tell you that this person is this or that. They will just tell you, this is what happened here. This is the number of cases and this number of deaths. So you might not know actually until maybe you look at the line listing or something that will give you the details of those cases to know what might be responsible to high number of the fatality. So I think for now, it is the countries that are recording the high case fatality rate that might be in the best position to explain to us what exactly are responsible for this a bit high number, a bit high CFR rate. Over.
Thank you very much for that response. I think with this pandemic, we still have a lot of questions that we can't clearly answer. A lot depends on the amount of data that we're collecting. As Dr. Wahid pointed out, we don't necessarily know the background of these patients in different parts of Africa, and we don't collect that data. So I hope that, I'm sure it's not what you might record as satisfactory answer because it's not clearly defined, but it's something that we do need to, we can explore further. So can I move on to the next question? And there are a couple of questions on this. I'm going to address this to Dr. Shinyo. You mentioned about the IPC Ring Approach, and there are a couple of questions. to explain that in more detail. So Dr. Shinyo, could you talk a little bit more about what you mean by the IPC Ring Approach?
Okay, so thank you very much, Valerie, and thanks for the question. So the IPC Ring Approach has 3 rings. That is to say that the IPC interventions have to extend beyond the healthcare facility and also look at the household of the case and also the community. So for instance, if we have a healthcare facility that is managing EVD, then we have IPC interventions in that healthcare facility as the first ring. And then the second ring will be the household of the case. In very rural settings, the guideline is to have all households within 500 meters of the household of the case. But in urban areas, the guideline is to have all households within 1,000 meters of the household of the case. And so within that second ring, then all the households in that ring need to be assessed in terms of the risk of transmission, and then given the necessary IPC and WASH intervention. The third ring then would be the community. So this would then talk about schools, churches, social gatherings, etc., beyond the second ring. And the idea is that in order to break the transmission of EVD, IPC has to extend beyond the healthcare facility that is managing EVD, but also with the household and the immediate community. Thank you very much.
Sorry, I was muted. Thank you very much for that very clear explanation. I think if there's still things that you don't understand or would like further explanation, please continue with the Q&A. And to those of you who put questions in the Q&A, in the first part of this session, we're really addressing questions that have arisen from the presentation. So there may be some issues that you're interested in and have asked questions that we might not have time to address. But thank you for the questions anyway. There's another question on triaging, and maybe I can address this to both Ms. Williams and Dr. Shinyo. This is about when there is an Ebola threat in the same areas you have COVID-19 infections. Are you triaging for both? So maybe I can just read this question. Please share dual triage algorithms as well as ideas on whether it would be appropriate to have 2 separate holding units, as holding the suspects of 2 different highly infectious diseases on one holding unit would be catastrophic. Would you like to comment? Maybe I ask Ms. Williams first.
Okay, thank you for that question. And yes, that's a great point. You know, right now we're still very much in the COVID-19 pandemic. As we saw with the first presentation today, across the continent, it's still with us. And so in the midst of that and with the threats of Ebola, how do we cope with triage? And so the answer is that yes, you could have 2 different algorithms. However, what we recommend is a single algorithm where you're doing the 2 at once, because it becomes cumbersome for staff if they're 2 separate processes. And really, again, what I want us to understand is with IPC, all the principles, you know, you're learning and you're being taught are meant to be applied regardless of the communicable disease. So it's not that we're learning IPC for COVID-19 or we're learning IPC for Ebola. We're learning principles that can be applied to the 2. And so it's very important that we look at this triage process as something that can be used for any It could even be for meningitis. It could be for anything, right? It's not just limited to what we're talking about today. So yes, you can have and should have a single process for triage. However, the important part of this question is what was stated about the holding area. So to screen for COVID-19 and Ebola, it can be done in the same place. However, once I suspect I have a COVID-19 person or patient, I should not put that person next to or within the same holding area as somebody that I'm suspecting to have Ebola. So that's one very important point, is that we should have separate holding areas for the different infectious diseases we are screening for. So I hope that's clear.
Thank you very much. Dr. Genio, do you want to add to that?
No, Valerie, I think Ms. Williams has really said everything that Ghana has or intends to do. We are also still at the early stages, but we anticipate a single algorithm, so where it is clear-cut how to separate the two at a point. And also to emphasize that, yes, the isolation and holding areas will be separate for the two cases. As much as possible, in a resource-poor setting, we don't even think that two separate screening processes is effective, because we have already invested in IPC measures in this COVID response, and we think it is a very good leverage to be able to match both at the point of screening, but then separate the holding and isolation. Thank you very much.
Thank you. So could I add on, there's a question here still about triaging. Is triaging only done at hospitals? Screening or temperature taking on public buildings or supermarkets, is this still triage? If one of you would like to answer that.
Okay, I can go ahead. Or Dr. Oshinyo.
Yeah, okay, Ms. Williams, I think I can take that. So, you know, in Ghana, we realized that using triage interchangeably with screening was a little confusing for our frontline workers. So we used pre-triage to mean screening, and then triage is, as Ms. Williams showed in her presentation, segregating into categories. So I would say that in marketplaces, in banks, in schools, we still do pre-triage, which is screening. And this is very widespread in Ghana. You don't, I would say 90% of the public places, you cannot really have access without giving yourself for pre-triage screening. So that is done. But usually it is just a temperature check. It is in the clinical setting that we add our tool for pre-triage or screening. So yes, I think in the community, there's still a form of screening, which is, I think, very useful to pick up. We have also picked up some suspected cases through that process as well, and it has been very helpful. Thank you.
Thank you very much. So there were a couple of comments about your photograph. I think it was Ms. Williams' photograph on the triaging, where patients were sitting close together. And I wondered if either or both of you could comment on how we can help people who stand in queues to stand 1 meter apart. I was just vaccinated this morning at one of our centers. And even though this is a hospital venue, standing in queues seems to make people want to stand close together rather than 1 meter apart. Do you have any experiences where you managed to encourage people to really socially distance within the queue?
Okay, I'll just share a bit about my own experience. Of course, I'm sure many of us are familiar with the visible cues that have been used throughout the pandemic, both on the floor as well as, you know, using things like seat blocking, where you block every other seat so that people can't sit next to themselves, So I think in this instance, we really need to look at how do we use our engineering controls and our environmental controls, because that is what will drive the human behavior. That's the parts of IPC and that's why environmental controls are superior to things like PPE, because when we make it physically impossible for someone to do something by engineering the environment for that thing, then it means that there will be compliance. So we need to be very innovative in the way that we set up these queues. So if we know that the screening area, for example, will get congested quickly, we could do simple things like using barriers and tapes to create a single file area that they can come through so that it's not possible for people to stand next to each other. We could also use things like wooden planks and other, just local solutions to create a flow that the patients have to follow, because they have to stay within, maybe you make a path and you block both sides of the path with the wooden planks, for example. So there are ways that we have to use engineering, and sometimes we have to go to the local artisans in the community. We've had hospitals that have engaged with, for example, carpenters and people around the area and the community to come and help them think through these types of solutions. So we as health workers may not have the answer, but we can always tap into those around us to find solutions that can help. And then of course, signage is also key, because we need to keep reminding people and educating them on the reason behind the social distancing, the reason why we need to do these things. Because of course, we've talked about fatigue. As fatigued as health workers are, the general public and our patients are equally fatigued with all these precautions and things we're telling them. So we also have to keep educating them. Over.
Thank you very much. That's very helpful. So maybe there's a very practical question. Maybe I can address other members of the panel. We discussed isolation rooms and putting patients in isolation rooms. Question is here, what is the duration after patients have left the isolation? Should cleaning be performed? And should the cleaner wear the level 3 PPE? Maybe I can address that at Lizzie from ICANN. Lizzie, are you there?
Hello, Prof. How are you? Sorry,
well,
I didn't get the
thanks. How are you?
question. I'm fine, thank you.
Did you hear the question?
Sorry, I didn't get the question.
So the question is, because we've been talking about isolation room, this is a very practical question about what duration after patients have left the isolation room should cleaning be performed, and should the cleaner wear the level 3 PPE?
Okay, thank you for that question. So in terms of duration on when the cleaning can start, once the patient has vacated the isolation room, the cleaning has to start. And from the previous webinars, I think we all remember that we use soapy water, and then also followed by a disinfectant. And then for the PPE, as we have always said, it is procedure-based. So if you are anticipating, there is the basic PPE that you put on as the cleaner. That is your protective apron, which is mostly what we refer to as the heavy-duty apron. And then you have your cleaner's gloves, or what we call the household gloves, and you have your masks on, and then you can, the gumboots for cleaning, and so that you do not damage your shoes, and then you can clean the isolation area, and then you can leave it ventilated, and once it has been cleaned and disinfected, it can be ready for the next patient to use. Thank you, and over.
And thank you very much for that response. Now, there are a lot of questions in the Q&A box on vaccines. And Dr. Shinyo briefly mentioned the vaccination program in Ghana. And I deliberately not addressed those vaccine questions because we were specifically looking at infrastructure issues. but we just have a few moments left, and the vaccination campaign across the continent is really critical in supporting our response to COVID-19. So I wondered if we could look at one or two of these questions before we close the Q&A session. I don't know, no, do I still have a little time for these questions?
Yeah, you've got about 5 minutes.
Okay, thank you very much. So I think there's a great deal of concern about strains of SARS-CoV-2 spreading across Africa. I don't know if Dr. Bakari wants to look at that. About the question is, can we halt the strains and the effectiveness of the different vaccines against the strains? I've rather summarized some of the questions and pulled them together, but I think that is that addresses some of the concerns. How do we halt the spread of these different more transmissible strains of SARS-CoV-2, and how effective are these vaccines? Because there's a lot of AstraZeneca vaccine on the continent, and some people have concerns about its efficacy. So Dr. Bakari, if you're there, I don't know if you wanted to address that.
All right. I think there are a lot of countries that are going into research to get this done. The study is still ongoing to ascertain which vaccine is more effective on which variant. But most important thing is that all the IPC measures that are on ground now are effective against all the variants that we have currently. So once we stick to these measures that we have been advocating for, I think the risk of transmitting COVID-19 will still be minimal. Even the COVID vaccine is still not 100% like once we are vaccinated, we are safe. There are still a lot of research ongoing to know at what level can we guarantee our safety. So there are a lot of things going on now in the area of pharmacovigilance and also immune response to these vaccines. So as we go along the response plan, so we continue to have updates for you. Over.
Thank you very much. I think that's a very good place to finish. I'm sorry we couldn't address every single question, but I think the point that we will still need our masks, we still need to adhere to social distancing, we still need to adhere to hand hygiene, in addition to accessing vaccination. Even when we're vaccinated, we still will need those measures. So let me stop there and thank you for your questions, and thank you to the panelists for answering the questions, and hand over to No to close the webinar. Thank you.
Thank you everybody for, I think, a great session. I'm sure we'll all agree that today we've had a great session. Thank you to the panelists. Thank you to the participants as well, and for the active participation. Just to remind you as well that every Friday we've got a French session. So if you'd like to register for that one, and then we've got our next session next Wednesday as well. So please do register again. And then the lectures as well will be available on ICANN or the ACDC websites, and will also be live streaming on Facebook. And then all sessions are recorded and will be made available to all that have registered. And also, just in closing as well, if you've got any questions that are still burning, please send them to Susan Cassie, Cassie being capital K, ESSYS at africa-union.org. And with that, thank you so much, everybody, and hope to see you next week again for another session.